now call Dave Thompson to attest to the fact there is life after smallpox. And this, I think, brings together the important point of the relationships with communities and working with communities. And welcome you, Dave.
Thanks, Dan. 4 or 5 years after leaving smallpox, we found ourselves back in Africa, in Chad and Cameroon, mostly in Chad. And what resulted was a very miniature HMO, very, very simple, extremely simple, but community-owned. If you remember Joel's hippo diagram, we were trying to deal and develop a healthcare system in that 95% village and home level. This is the area that we are working in, southern Chad. This is the sub-prefecture of Lere. Roughly 100,000 people. The majority group, ethnic group, was Mundang. They're mostly subsistence farmers with a few fishermen. It's rolling savanna. It used to be forested many years ago. Now it's very poor, rocky soil. The only industry is the government-owned cotton gin outside of town. Communications were very limited. One all-weather road east to west, which was graveled and hard to travel even in the rainy season. No telephone, telegraph. Again, this is back 1975 to 1987. There are really multiple healthcare systems that are operating in this situation. The first is the traditional or decentralized healthcare system that they've had for centuries. It consists of the healers, diviners, bone setters. The latter I actually referred patients to. Then there's a centralized system that we all worked with, the government hospitals. There was one government hospital, 75 beds at its maximum, 1 MD, and 2 very small clinics. There was one small private clinic at the periphery run by the Catholics. I came there as a Lutheran missionary. The other system is what I call the chaotic or emerging system, and that's the marketplace, where you can buy almost anything in terms of medicines. And there's also the system where relatives in the big cities send supplies and medicines, particularly injectables, to their relatives. Traditional system is trusted, it's available, and it's affordable. Modern medicines are powerful, particularly anything that's injectable, but access is limited, it's difficult to get there, and it's expensive. And then finally there's the discouraging idea that through the colonial era developed that health care is something that's provided by somebody else. It's something I can't manage, therefore it's not my responsibility. I worked in this government hospital 2 mornings a week as part of my work. This was built in the German colonial era, pre-World War I. On a busy morning in the dry season, you'd maybe find 200 people lined up outside. They would be triaged by one nurse who would see and treat most of them, and then send maybe 15 or 20 to the physician. This is the adult ward. Many of you have been in situations like this. Maybe 6 beds with a mosquito net in good times. Families provide all the care, food, etc. For better or for worse, we also started seeing patients at home. Patients would come to us saying they'd gotten poor or inadequate treatment at the hospital. We found it hard to turn them away. And so often, early in the morning, late in the afternoon, this is what we would do. And my wife, Joanne, helped with this, and I'd like to pay particular word of appreciation to her. And to all the wives who supported us through the smallpox program and their families. I was an idealist. I worked formerly with a lot of idealists. And our objective here was simply to return responsibility for health care to the people, to develop a locally owned health care system that was self-financing and sustainable, that could serve as a foundation for future services as time went on, and that could be reproduced without a great deal of input from the outside. And finally, based on David Morley's work in Nigeria earlier, we wanted to decrease the under 5 mortality by 50%. We wanted to use all the available resources to serve the entire population, not just those who happened to cross our threshold into a hospital or clinic. We wanted to make care accessible, to bring the care to where people live. And to do this, we needed volunteers, securistas, as we call them, the health workers, or the matrones, the traditional midwives. We needed village health committees that were functioning and took responsibility. We needed indigenous leadership. And this was provided with a very small staff of salaried people who ran the central program. And we needed a representative and functioning board of governors. Finally, we insisted on using only available and affordable technology. That meant I used a mobilette rather than a car. Our targets were simple. We wanted to be able to diagnose malaria, prevent dehydration by using oral rehydration salts, and do basic immunization, and provide clean home deliveries. The program was actually begun by a small group of Catholic sisters in the early 1970s before we arrived. We arrived in 1975. I turned over leadership to an African nurse in 1982, and then remained on as an advisor till 1987. The program continues to grow today under local leadership. The program is organized at 2 levels. At the central level, we have what's called the Bureau Central, which is financed by the sale of medicines to the health posts and their health workers. There we have a small group of salaried staff who provide supervision, training, medicines, vaccines, and government liaison. The other level is the village level, which is independent. It is financed by the sale of medicines. We sell the medicines at a profit to them. They sell medicines at cost, create a revolving fund to purchase another round of medicines. The health workers are volunteers, basically. They're young farmers. And the village agrees to give them 2 sacks of corn, 2 liters of oil, and some field work during the year. And just, again, the 2 levels of organization. The village level, each village had a health committee, a health worker, a midwife. Each village then was a member or belonged to a village group. Each village group sent a delegate to the Board of Governors. The Board of Governors also had representatives of each major religious group in the community, and the hospital, and the health workers. All of this was under the general authority of the médecin-chef of the local hospital. On the other hand, it was independent enough to hire and fire and run the program, which was crucial. There were some very, what I called, crucial moments, and some of them were in fact battles, friendly battles. One was in developing a long-term leader who turned out to be a nurse. Next was creating a functioning Board of Governors, getting recognition as a secular NGO. And again, this started by a group of missionaries. The program evolved to a secular, community-owned program. And the last was establishing true community ownership. The church and mission here simply acted as a catalyst. Participating villages became the owner and the driver, but we retained a very important relationship with the government and existed under their umbrella of protection. We would go out into the villages during the dry season to recruit villages and health workers. This is a village chief calling a meeting. We would meet under a tree, explain the program to them, And basically, they had to raise enough money to buy the first supply of medicines, choose a health worker, and build a health post. We brought these men in once a year during the dry season for a month of training. This is our center. This is one of our first classes. And this is a typical health post. These men are all young farmers. They're chosen only because they have a reputation for honesty and integrity, and they can speak and read French or the Mundang language. They're available in the morning before they go to their fields, and in the afternoon when they come home. Immunization was a very critical part of this program. And we would do up to 1,000 people a day with simple syringe and needle, using teams from our central office and the hospital. My wife Joanne helped out on occasion in the early years, and our children, when they were on vacation, would come with us. One of the most important moments in the history of this program occurred in 1982, when I was about ready to go home on a home leave and turning over responsibility to the nurse, the gentleman in the red in the middle. And we had a very formal ceremony in the office of the Superfay with representatives of the Board of Governors, the hospital, and the local administration, where I, a white doctor, deliberately and formally turned over responsibility to a black African nurse. One of his phrases, I won't go there. This is the Board of Governors. They're continuing to run this program today. And the question continues to be, are we howling at the moon? Are we in fact making a difference? Thank you.